pleasure to introduce our speaker here, Wei-Chun. And I assume almost all of you know Wei-Chun. He's a third-year B-Mice PhD student on an NLM fellowship. And Wei-Chun was from Taiwan, and he's an MD by background, and he's done some training in traditional Chinese medicine. After doing his MD and doing some clinical training in Taiwan, he came to the U.S., where he was at Carnegie Mellon University, and then got a master's in biomedical engineering. Worked for a little while, came here, and he's done some really nice work. He's actually presented at AMIA 2 years in a row and done some stuff involving machine learning, computer simulation models, and he's going to be talking about some of that today as applied to eye care. So Wei-Chun, welcome.
Thank you. Okay, hello everyone. Today I'm going to talk about the application of machine learning for glaucoma using EHI data. In the beginning, I will thank you for my advisor, Mike and Michelle, and my committee, Ayin Chen, and all my coworkers in our research team, and our department, DMICE, and our study was funded by NLM Training Grant. Here is the outline for today's presentation. We will start from what is glaucoma and important for the risk prediction and the progression prediction of glaucoma, and explore the machine learning application in glaucoma, and our approach for the prediction model of glaucoma. And then we will talk about the research question and our potential projects. So what is glaucoma? Glaucoma is a group of eye disease characterized by progressive degeneration of optic nerve and visual field loss that are irreversible. In addition, glaucoma can lead to irreversible blindness. In this presentation or study, we will focus on the open-angle glaucoma, which is the most common form of glaucoma, about 95%. The figures here shows the mechanism of glaucoma. Left side is the normal anatomy of eye. We can see the aqueous humor will outflow from the trabecular meshwork. But in glaucoma patients, the trabecular meshwork was blocked, and the aqueous outflow decreased and the resistance increased. So that will increase the intraocular pressure, and then for long term that can damage to the optic nerve here. So glaucoma is the second leading cause of blindness in the world. And as we just say that the vision loss and the damage to the optic nerve is irreversible. There are about 57.5 million people in the world had glaucoma in 2015, and this number is still increasing. In US, there's about 2.8 million people had a glaucoma, at open-angle glaucoma in 2010. Currently, the prevalence of open-angle glaucoma in US is about 1.9% for the population older than 40 years old. There are several clinical examinations and tests can help physicians to make diagnosis of glaucoma, include intraocular pressure, the visual field function that can measured by the visual field loss. This is the visual field test, and some damage to the optic nerve or the retina structure change. And some image device can use to measure the retinal nerve fiber layer can measure by the OCT. That could be a useful tools for improved diagnosis. However, for glaucoma, there are no single gold standard tool can make the diagnosis. The treatment glaucoma include medication, laser, and conventional surgery. The medication include topical medication and eye drops. The goal of medication is one is to increase the outflow of the aqueous humor or reduce the production. And both the laser surgery and the conventional surgery was try to increase the outflow. Trabeculectomy is the most common. it's the most common conventional surgery. It might remove part of the trabecular meshwork. Although we have several clinical examination tools to help to diagnose the glaucoma, open-angle glaucoma develops very slowly over time without pain sensation. And the lacking of clear symptom, the only sign can find is like gradually progressive of visual field loss and start from the peripheral field. So that is very important for the screening of glaucoma or make prediction of the patient risk develop glaucoma. So currently the most popular use prediction model in clinical is come from two studies. One is ocular hypertension treatment study and the European glaucoma prevention study, which named as a STAR score system. Is a method for estimating the 5-year risk that an individual with ocular hypertension will develop primary open-angle glaucoma. Here is the equation of the prediction model. We can find this method include the age and several clinical measures like vertical cup desk ratio, intraocular hypertension, intraocular pressure, and central cornea thickness, and the visual field pattern standard deviation. However, for the diabetes, it's still controversial. In the ocular hypertension treatment study, they found that diabetes is a protective factor for glaucoma. But in this study, they did not include a participant with retinopathy. And this finding is controversial for some other study. So in many clinical tools for predict the risk of glaucoma did not include diabetes. The STAR score was external validate from several studies and pretty convenient use in the clinical setting. But there's still some limitation of this tool. This model does not include other major risk factors such as the race or the family history. Actually, in the European study, all their participants are Caucasian, and they did not recall any family history information. So here, glaucoma is a multi-risk factor disease. So here is the list of possible risk factors of the onset of glaucoma, include age, gender, race, family history of glaucoma, the level of intraocular pressure, the myopia, type 2 diabetes, the hypertension or hypertension, vasospasm, and a central cornea. So the second limitation of this model is the model used only the baseline measure of the predictors. We still remember include the age and several examination measures, but lacking accounting for the change or fluctuation of these predictors, particularly for the intraocular pressure, is a pretty important risk factor of glaucoma prognosis. And in addition, the model used only for patients with untreated ocular hypertension, but about 50% glaucoma patient, it's normal tension. That means their intraocular pressure is not elevated. And this model cannot use the information from after patients started glaucoma treatment. So other than the risk prediction of glaucoma, glaucoma progression is another important issue. This figure shows the progression of glaucoma is very different among different patients. The line A is just show the patient of the vision function decrease among the age, and the line B and line C shows with similar symptom patients diagnosis of glaucoma at different ages. If the patient is younger, then the progress might worse, and the line E shows some patients just have very worse progression of glaucoma. So the this difference between the glaucoma patient of the progression makes it more difficult to make the prediction of the glaucoma prognosis. And as we see, the glaucoma has a multifactor and a very complex disease. So this complexity makes the disease it's even more hard to make the prediction. And based on the literature review, the previous study for the progression prediction model mainly use one or two clinical feature like visual field change or change of intraocular pressure. They try to use like single or two measure to make the like use shortened measure to make the long-term prediction. However, the similar situation is many risk factors are not considered or included in this prediction model. So as the laking gold standard tool for the glaucoma diagnosis and the medical data of glaucoma is high complexity and high dimensional. So many studies try to use machine learning method. It might be a good way to handle this kind of high dimensional data to improve the diagnosis or progression prediction of the glaucoma management. Based on the literature review paper, the most previous published study in the glaucoma used the image data for improved the diagnosis. This paper is a review article published in British Journal Ophthalmology in this year. And there are about 38 studies mainly use the image data and functional data such as visual field change to improve the glaucoma management. And 31 studies focus on improved diagnosis, and only 6 studies focus on improve the prediction of prognosis. And only 1 study tried to predict the need for the surgery of glaucoma patients use EHR data. So as we mentioned, that there are many risk factors of glaucoma was recorded in the EHR, but there are very limited studies try to use EHR to develop the model or make the prediction. So based on our literature review paper just submit and accept this year, application of artificial intelligence to EHR data in ophthalmology, we try to find all study use the AI techniques with EHR for the eye disease. And we found only 2 studies use machine learning method with EHR data. One study was done in UCSD. They try to predict the need for surgery intervention within 6 months. And the second study was they used the EHR data, develop the phenotype of glaucoma, try to improve the performance of image classifier. So briefly summary, based on our discussion and the literature review, we found there are lack of risk assessment tool for normal tension glaucoma patients, and the current prediction model cannot include the information after treatment, and there are several limitations of this model. And they might have the need for comprehensive model for glaucoma progression predicting, since currently most studies use only 1 or 2 measures try to make the prediction. And machine learning application was widely used for glaucoma management, but they are mainly based on image data, and only 2 studies use machine learning method with EHR data for the glaucoma management. So we are thinking secondary use of EHR with machine learning model may be a possible direction for the improve the glaucoma risk prediction or their management. So the first step, we explore the available EHR data in KCI Institute. There are several groups listed here, include system disease, family history, patient data like age, gender, or race, and some eye measurement like intraocular pressure, visual field change, and include clinical notes and medication information. As we mentioned, the medication is the first-line treatment of glaucoma, and the the compliance of medication is very important to prevent the disease prognosis. However, extracting accurate and correct medication information from EHR system is not an easy task. For example, this is two example clinical lists and clinical notes from the KCI Institute. We can see in this case, the clinical list is mismatch of the clinical notes record. And in this case, there is no medication list information. Probably the patient get drug from other sites, but the physician record their medication usage in the notes, but not in medication list. So as we show in the previous figure, medication list may not be updated, and the patient may take medication from different sites. And sometimes the same drug can have a different name. And the physician sometimes record the meaningful change like medication adherence, medication tolerance, or the reason used the medication in their chart or in their progress note or clinical note. So this information may not be get from the medication list. In fact, there are several studies already try to explore the problem of accuracy of medication list. In the ASHVAC study, she found that 25% medication were mismatched between the progress note and the formal medication list in the EHR system. And Linsky study, they found that 60% patient had at least one medication discrepancy. Other than the medication list problem, the medication adherence is another very important issue for the glaucoma and all chronic disease. In U.S., at least 50% patients with chronic illness have an issue of non-adherence medication. And the medication non-adherence cause a lot. We can see there's about $290 billion in U.S. And this figure shows several annual costs of different chronic disease. So for glaucoma, medication non-adherence is different from different studies, from the 24% to 59%. And as we just discussed, the sustained and consistent patient medication adherence is critical for prevent disease prognosis. But there are several factors affect the glaucoma patient medication adherence. For example, the eye drop used for the glaucoma is, for some patients, is painful sensation, and they don't want to continue use it. And the glaucoma, open-angle glaucoma, is a non-significant symptom, and only the visual field change from the peripheral can find. So that's make a lot of patients, they have no motivation to continue use the eye drop. And a lot of glaucoma patients are senior people, so the forgetfulness is another issue. Generally, there are two ways to measure the medication adherence. First is direct method, include the observation, measure of drug concentration, and adherence monitor device. Monitoring device is the most accurate way, but it's cost and not so convenient. And indirect method include the patient self-report and pill counts and rates of prescription refill. However, this indirect method from the structured ER data like pill counts and the rate of prescription, the accuracy is questionable and sometimes cannot represent the actual medication adherence of patient. So for this problem, we found the structured EHR data for medication adherence may not comprehensive enough, and we might need some way to get the medication adherence information from clinical notes. Especially in KCI Institute, glaucoma specialists always recall pretty clear, detailed information about the medication adherence in their notes. So from the previous literature review and discussion, we raised several research questions here. For the EHR data with the medication information, we want to know how can we examine the data quality of medication list since we found there are some mismatch or missing problem. And we also want to know how can we get the medication adherence information from clinical notes. And for the glaucoma onset or progression, we want to find some way to efficiently use EHR data to improve the risk prediction and the progression prediction, since there are some limitation and difficulty for make prediction on current study. So here we will start our potential project to address these problems. The first potential project is predicting medication adherence of glaucoma patient using natural language process. Since we want to get the information from the clinical notes, so we are thinking, can we use natural language process to get useful information from the notes? And based on our literature review on literature search on the PubMed, there are only 4 studies use the natural language process to get the medication adherence information from notes. And the note study focus on the eye disease. So this, using the natural language process to extract information of medication adherence as probably is a novel way to manage the glaucoma disease. Natural language process is the subtype of machine learning used to add the computer or the machine to understand human language, and there are several different group of algorithms. In this study, we might use the syntax in the group of the algorithm of the group of syntax or tokenization that we can get useful information in a long text. So here is some example of people do the annotation of the discharge node in previous studies. So we can see some sentence like poor medication complaints, skip medicine or fail to take medicine at the right time, or the not be following the complaint with her medications. This kind of sentence will be noted as a poor medication adherence. So here is our possible methodology for this project. We need to develop a vocabulary of the terms describing the medication adherence and the non-adherence. And we need human, like physician or researcher, to code it, to code the training note as medication or medication adherence or non-adherence. And we will use this training node to train the natural language process algorithm to identify the instance of medication non-adherence. And we can evaluate the precise and recall measurement of these algorithms. Excuse me. Our second project will be data quality measurements of medication lists of glaucoma in the EHR system. Since we found there are some problem of like mismatch of medication list or the no medication list for some patients. So we want to use the natural language process, extract the medication information such as drug name, dosage, frequency, reason for use from the clinical notes, and we can compare this information to the medication list and do the data quality measurement of this information. The third potential project will be predicting the certain ear risk for developing primary open-angle glaucoma. In this project, we are not only focused on the ocular hypertension patient. We also want to create a prediction model for normal tension ocular pressure patients, and we might use some the EHR data after the patient start treatment that we can use some measure change or a fluctuation issue. So here is some possible predictors based on the risk factor related to the glaucoma onset and some change of the clinical mention. And right side, the blue, and this one shows the predictors of star scores. So we can remember there are only age and several clinical measures used for this model. So we hope our model can have a different information input and for different type of patient, for the normal tension patient. For this study, there are several possible machine learning algorithms we can use, include a logistic regression, elastic net, support factor machine, random forest, gradient boosting machine, and artificial neural networks. And we also can use some hybrid model that's like folding classifier system that we can combine different mechanism algorithm to get a better performance of the model. Here is a figure illustrate the basic idea of these machine learning models. In linear regression, we assume the input and output data have linear relationship, and we can use it to make prediction of the given data. Logistic regression, like here, is an extension of the linear regression. Non-linear regression function and logistic function will convert outcome variable from the continuous to binary outcome based on difference ratio. And another way elastic net we might use is the improvement of linear regression and logistic regression. It's a regularization method, so that not only want to reduce the prediction error, also want to reduce the complexity of whole model. And support factor machine is another very popular machine learning algorithm. In this method, we will create a hyperplane and can classify the input data into different groups. And this method can use for the new data and try to split them into similar categories. And another two example method will be random forest and gradient boost machine. Random forest is an improvement of backend decision tree. You can see the illustration figure here. Backend decision tree is a bootstrap aggregation method that the original data set will split to several sub-data sets, and each sub-data set will develop a decision tree. And we will aggregate all results from each decision tree to get the final result. And in random forest, the difference is in random forest, we will get certain number of feature randomly from the original data set. That will reduce the similarity between each decision tree. And the gradient boosting machine is another ensemble method showing here. We will start from a weak learner and update the weights and some information to get a stronger learner. And then the artificial neural network is the fundamental algorithm of the deep learning. Each layer in the neural network will input and output information to the next layer, and we will get the final information of the final layer. But we cannot see the output information between the hidden layers, so that's why an hidden layer. So that's the general idea about the potential algorithm we can use to develop the prediction models. So here is our possible methodology for this study. We need to extract the HRR data, probably comprehensive HRR data for the glaucoma patient from the clinical warehouse from the KCI Institute. And then we need to prepare and preprocess the data and develop the machine learning model and use cross-validation method to avoid overfitting and evaluate the performance of prediction model. In this study, if we can get enough data for ocular hypertension patients, we can compare the result of the machine learning model and the star score system, the current used method for the risk prediction. And the fourth potential project will be predict the progression of glaucoma using machine learning method with EHR data. In this potential project, there are two possible outcomes we can use. First is the visual field change in certain time period, and we can try to predict the probability of patient need surgery within certain time period. As we showed before, we can see the progression of glaucoma patient are different. So if we can predict or find the patient in the early stage, we can try to make the intervention earlier. That can try to help like patient with the worst progress to the better prognosis if we can treatment earlier. The possible predictor of the progression prediction model is a little different from the onset. The risk prediction model, since the risk factor of the progression is a little different. So I should list the possible predictor in EHR system, and some chronic disease may need to include. In addition, if our first and second potential project get a good result, we can get this information from the unstructured EHR data like clinical note, progress note, and we can get this the information about the medication usage, medication adherence, medication tolerance. And this information from the unstructured data can integrate with the in our prediction models, then have the potential to improve the performance of the models. So the possible methodology of this prediction model is similar to previous. We need to extract data and prepare process data, develop the model, and train the model, and evaluate the performance. In addition, since the progression is a continuous and time series problem, so we might use different time point as our input data to develop the prediction model. For example, in this figure, we can see if we can use the comprehensive data before the patient already diagnosed as glaucoma, we can try to, if we can make the prediction of their prognosis, we can have a very good early intervention. Oh, sorry. So we might use different time point as input data set, and we might refine the time series input data like visual field change, ocular pressure change, this time series data as a supervised learning problem. Or we can try to choose some time series forecasting model such as auto-regression integrated moving average model. This kind of prediction model to solve this time series problem. The auto-regression integrated moving average model is it's an integrated way of the regression analysis. It's try to measure the strength of one dependent variable to other changing independent variables. It's a combination of three parts, include the auto-regression. It's the change variable based on its own prior value. And the integrated part means that the variable value are replaced by the difference between the data value and the previous value. And the moving average is a way to filtering out some noise or extremely value on some time point, so that it's a moving average. So this is another possible algorithm we can try to handle this time series problem. So for summary, based on the literature review and the previous presentation, we found that there are some limitations of current risk prediction model and the progression prediction model. So there might be a need for a more comprehensive model for glaucoma risk and progression prediction. And we found most machine learning application for glaucoma are mainly based on image data, and they try to improve the diagnosis. Yeah, only few studies try to use the EHR data with machine learning model for manage the eye disease and include the glaucoma. And then the natural language process might be a useful way to address problem of the accuracy of medication list and the medication adherence information from the clinical note. And the secondary use of EHR data with machine learning model may be the direction we can try to use to improve the risk prediction and progression prediction. Okay, thank you for your listening, and open to any question and discussion.
Hey, thanks, Wei-Chun. You mentioned a number of other categories of EHR data. Why focus, in this case, so much on medication data as opposed to the other types in the EHR? Do you just know from other literature that that's the most predictive, or what? Why the focus there?
Yeah, it's a good question. One reason is that most other type of EHR data is pretty good recorded in structured EHR data, like sheet or table. Sorry, we can extract directly. However, as we see there, the medication information is some problem in the medication list. It's a type of structured EHR data. So that's why we probably need to get some information from unstructured EHR data like clinical notes or progress note. It's not just easily to get a table and do the analyze. We need to some way to get it.
Is there any research about data quality that's specific to ophthalmology records? As you were kind of reviewing the literature, did you find any? And are there any, as you've been doing this work, have you found any problems that are specific to ophthalmology records?
I haven't done a comprehensive or exhaustive literature review for the medication list problem of ophthalmology, but there are some examples, like, let me find. So this study is actually they do the medication list accuracy in some eye disease. It's a microbial keratitis. It's a kind of eye disease. So there are some studies, but it's probably I need to do the exhaustive literature review on this question. Yeah. Thank you.
Thank you for your presentation. I also had a question on adherence. In the TOPAZ study, a lot of those examples were questions of, or had text about non-adherence, like they didn't take their medications. It looked like you were also trying to predict adherence. How would that be defined? And then your previous also showed that it'd be hard to get a gold standard list of what the patient should be taking.
Yeah, this for the medication adherence problem, we might not try to predict. We try to create a classifier to see if this node should be considered as medication adherence or non-adherence. So
I see.
So that's we need to develop a vocabulary of term of medication non-adherence, and we need human to code it, the training sample data nodes as medication or non-medication adherence.
So it'd be like a heuristic indicator that the patient is not adherent rather than a numerical.
Yeah, that's why
yeah.
we need natural language process to try to get this information from nodes.
So what do you think the limitations are of trying to do this with one institution's worth of ophthalmology data?
You mean the medication part or prediction model part?
Well, any or all of it. I mean, we have a certain kind of
Yeah.
referral institution and tend to be sick patients and,
Yeah.
those sort of issues, how representative is this compared to whatever kinds of samples and patient populations that other work has used. So, what do you think about that?
Yeah, the generalizability is always a problem for if you perform a study in single or even two institute. So especially for the medication adherence or something that recorded in the notes that could be very different from the different hospital. So one possible way is like we have seen there in UCSD there some research group already try to use EHR data make the prediction of like the patient needs surgery or not. So that's a possible way if we can get some good result, and we can try to work with other group in different institute if they have interest to use EHR data make a prediction of the glaucoma management. General. Yeah. Yeah, that's a good question we probably need to address in future study.
Yeah, Aaron, I think that's a fair question. It's a good question. One possibility is that Aaron, that's a really good question. I think one possibility is that within the KC practice, there's a glaucoma service that sees exactly that type of population, Aaron, that you mentioned, and there's also a comprehensive eye service that's more of a general eye doctor, and that may be one way to look at some of these issues, because they'll both treat patients, some of these patients with glaucoma. But it's a really good point. I mean, some of that can be done through the OHSU data set, and some of it may just need to be externally generalized.
I wonder if, when putting the data set together, you have to think about, matching patients with patients that don't have glaucoma in order to have sort of appropriate baselines. If we've got mostly patients that are mostly sicker, and the bias results in one way or another. So, especially if you're looking at EHR data and medications and things that aren't really specific to glaucoma or even to eye disease, and you're looking at other factors. Do they have diabetes, for example? Lots of patients without glaucoma that have diabetes, and you'd need some sort of baseline in there in order to help sort of cover the range of the space. So that's something to think about.
Yeah.
Nice presentation. I appreciate that you laid out 3 potential projects in your symposium. I think that's great. Could you go back to how you are measuring medication adherence? You listed some methods. Direct methods and something else.
Here?
No, it was like direct methods and then.
Oh, direct method.
Yep. Oh, yep. Okay. So I will just speak from a family member's perspective. It feels like pill counts are actually pretty easy. They have pill boxes. If they actually use the pill boxes, then I can say to my family member, who remains nameless, I see all the pills are still in yesterday's box. So it's pretty obvious that he hasn't taken those pills. But eye drops are not. If I'm not physically there, I don't know whether he's taken an eye drop. I don't know that you're going to do blood or urine tests, but how do you know whether someone has put their eye drop in? If it's self-report, and you ask my particular family member, he would think he's doing it every night, but I'd have no idea.
Yeah, that's the essential problem of indirect report method. So if we can use natural language process, get information from clinic notes, it's still the self-report to the physician and physician record it. So one possible way is, as we mentioned, the adherence monitor device is the most accurate, but the cost and inconvenience will be a problem. So one possible way is to do an external validate study like use the observation or the monitor device to compare the result to if we get the result from the natural language process. But using natural language process itself cannot solve this problem. It's an initial problem for self-report. Yeah, so yeah, that's good.
There are some researchers out there that in ophthalmology and glaucoma specifically that are using special medication bottles that you can at least figure out if they've opened the bottle at certain times. Yeah, but it's still not going to know if you've actually made it in your eye, but at least they would know. Although it's still very early work.
Jen, if you wouldn't mind just telling the group, because I think one of the issues in terms of progression risk and using the EHR data to predict, like, is someone getting worse or does somebody have glaucoma? Can you give the group a little bit of a sense of how good the current models are at doing this? Because that's, obviously in your thesis, you'll want to do something that's as good or better than what the current is.
There are two types of prediction model currently used. One is for the risk prediction. That's in the score system list here. And this model was external validated by several studies. And the average F score, that's the ROC-AUC score, is about 0.7, is about 70%. And the result of other prediction prognosis model, the result is varied. It's not very clear number. But the problem of some of this study is they just use certain, like, one or two mixture. And for kind of patient, they have a lot of exclusion criteria. It's the same situation we can see in the STAR score. They exclude diabetes, patient with retinopathy, and the other issues. So the goal of this study is, can we develop a more comprehensive prediction model?
So just in terms of what we're talking about, a 0.7 AUC isn't, it's better than random, but it's not very good. What would be clinically useful? How high of a performance, and I'm not saying that you have to, achieve that to have a decent dissertation, but how high a performance, or what's the minimum performance level that would be, clinically useful, and, for whatever that intervention would be that's based on that?
Yeah, that's an interesting direction. I think it could be a cost-effective problem. So that means even the prediction rate is not very good, but if we can early intervention for some patients, then we can reduce the chance to blindness, and we can try to calculate the cost-effective. That probably worth to do that. But it's a very interesting direction for evaluate for the prediction model. Thank you. Okay, thank you guys.